Health Advisor at the Office of Disease Prevention and Health Promotion, or ODPHP. ODPHP is within the United States Department of Health and Human Services and manages the Healthy People Initiative. Next slide, please. Before we begin, a quick note that the speakers and moderators for today's webinar do not have any commercial relationships or conflicts of interest relative to today's education activity to disclose. Next slide, please. We're pleased to announce that today's webinar can submit for select continuing education hours, and those select hours are listed on this slide. Next slide, please. Following the webinar, participants will receive an email from cpd@confex.com with instructions on how to obtain continuing education credit and certificate. And that email is listed on this slide at the bottom of this slide. Now let's focus on today's event. Today's webinar is the 7th installment of the Healthy People 2030 webinar series. For those new to our series, each year ODPHP hosts quarterly webinars that feature the latest data on select Healthy People 2030 objectives, cover important public health topics, and feature states, communities, or organizations working to achieve the Healthy People 2030 targets through the implementation of evidence-based interventions, programs, and policies. You can join our Healthy People listserv to receive real-time updates on the dates and themes of upcoming webinars. Next slide, please. Today's webinar is titled Injury and Violence Prevention Strategies for the LGBTQ+ community. Experiencing injury or violence can have a lifelong impact. People can suffer short-term effects such as missing work or school, and long-term effects such as chronic illness or death. Homicides, physical assaults, and bullying are important public health concerns in the United States. Healthy People 2030 focuses on reducing different types of violence, and during today's webinar, we will review strategies to reduce violence and build communities that support thriving and well-being. We will first hear from Carter Blakey, Deputy Director of the Office of Disease Prevention and Health Promotion, and she'll cover the importance of the 3 Healthy People 2030 objectives featured today. Following Carter's presentation, we will hear from David Huang, who is a branch chief of the National Center for Health Statistics, Health Promotion Statistics Branch. Dr. Huang will provide details on current progress toward meeting objective targets for the 3 featured Healthy People 2030 objectives and review differences observed across population groups. Lastly, Robin Gao will discuss Bradbury-Sullivan LGBT Community Center's work related to strategies to mitigate bullying and violence against LGBTQ+ populations. The Bradbury-Sullivan LGBT Community Center is a Healthy People champion. You can learn more about the Champion program by visiting the Healthy People 2030 website. Following these presentations, we'll have a moderated Q&A with these speakers, as well as a Healthy People 2030 LGBT Health Work Group representative, Christina Dragon. We encourage you to submit your questions into the Q&A feature located at the bottom of your screen throughout the presentation today. We'll do our best to address as many questions as we have time for. Now it's my pleasure to transition the webinar over to Carter Blakey to provide the overview of today's theme and featured objectives. Carter?
Great. Thank you, Debbie. And a huge thanks to everyone who's tuned in today. We're excited to have you join us. So I'm going to start with a brief overview of our featured objectives. So we can go to the next slide, please. Okay, thanks. So the injury and violence prevention objectives included in Healthy People 2030 cover areas such as motor vehicle safety, self-harm, work-related injuries, and a range of other topics. So injuries and violence affect everyone, regardless of age, race, or economic status. And in the first half of life, more Americans die from injuries and violence, such as motor vehicle crashes, suicide, or homicides, than from any other cause. including cancer, HIV, or flu. So the featured objectives in today's webinar include IVP 09, which is reduce homicide. So this objective was elevated to a leading health indicator, or LHI, for this decade, as denoted by the LHI icon you can see on the slide here. So LHIs are a small subset of high priority Healthy People 2030 objectives selected to drive action toward improving health and well-being. And objective IVP 9 is managed by the Healthy People Injury and Violence Prevention Work Group. And the second objective featured today is IVP 10, reduce non-fatal physical assault injuries, which is also managed by the Injury and Violence Prevention Work Group. And the third objective featured today is LGBT 05, reduce bullying of lesbian, gay, or bisexual school students, high school students, managed by the LGBT Health Work Group. So these three objectives are Healthy People 23 core objectives, which means that they'll be tracked throughout the decade, and progress toward achieving their targets will be updated as data become available. So as core objectives, they meet several criteria, and those are they're measurable. They have specific targets to be achieved by the end of the decade. They reflect high priority public health issues and are associated with evidence-based interventions. They have valid, reliable, nationally representative data, including baseline data no earlier than 2015. And they're expected to have at least 3 data points throughout the decade to assess any trends. So next slide, please. So this first objective, IVP 9, focuses on reducing homicides. So since 1981, homicide has remained a top leading cause of death for the 1 through 44 age group. And according to the Centers for Disease Control and Prevention, in the United States, more than 7 people die of violent death per hour, which includes homicides and suicides. So this persistent public health challenge includes major disparities by age, race, and ethnicity. Then implementing strategies that address factors contributing to the risk of homicide and homicide disparities is an essential step in addressing the Healthy People 2030 leading health indicator. So preventing violence in communities will help our nation move closer to our Healthy People 2030 vision, which is a society in which all people can achieve their full potential for health and well-being across the lifespan. So next slide, please. Great. So since the inception of Healthy People in 1979, violence prevention has been a priority of the nation. Violence can limit life opportunities. It can lead to emotional and physical health problems, and of course, shorten lives. IVP 10 tracks non-fatal physical assault injuries. And in Healthy People 2030, a non-fatal physical assault injury is defined as an injury from an act of non-fatal violence where physical force by one or more persons is used with the intent of causing harm, injury, or death to another person, or even an intentional poisoning of another person. So for decades, young persons have represented a substantial portion of patients receiving treatment in emergency departments for assault injuries. And some youth are at greater risk of violence than others. So, for example, sexual minority teens are more likely to experience multiple forms of violence compared to their heterosexual peers. And our speaker today, one of our speakers today, will review approaches that seek to reduce violence among lesbian, gay, bisexual, transgender, queer, or hetero, or questioning plus youth. So we've really got to focus action across populations and age groups to address this important public health challenge. So next slide, please. On this slide, you'll find several evidence-based resources which the Healthy People 2030 Injury and Violence Prevention Work Group provided to support efforts to address these featured objectives. So we'll move on to the next slide, please. Great. So this final objective that's featured today is focused on violence prevention and sexual minority or lesbian, gay, or bisexual youth. And as mentioned when I reviewed the last slide, sexual minority teens are more likely to experience multiple forms of violence compared to their heterosexual peers. So objective LGBT5 tracks bullying of lesbian, gay, or bisexual high school students. So the LGBTQ plus youth consistently report higher rates of bullying, being threatened or injured with a weapon, and dating violence. They're also more likely to miss school because of safety concerns. So now high school students who identify as lesbian, gay, or bisexual are almost twice as likely to be bullied as those who identify as heterosexual. So students who are bullied are more likely to have depression, anxiety, and sleep problems, and to drop out of school-based programs to reduce violence that can help prevent bullying of lesbian, gay, and bisexual students. So next slide, please. So on this slide, you'll find several evidence-based resources, which the Healthy People 2030 LGBT work group also provided to support efforts to address the featured objective today. So additional examples of strategies to address bullying and violence against LGBTQ plus populations will be shared later in today's webinar by the Bradbury-Sullivan LGBT Community Center. So before we move on to that presentation, I'd first like to welcome David Wong to make his remarks.
All right, thank you, Carter. I think we can go to the next slide. Great, and one more slide, please. I'm pleased to be here with you today to share data for the 3 Healthy People 2030 objectives that have been chosen to frame our discussion on violence prevention. As Carter mentioned in her presentation, the measure on homicide deaths is a leading health indicator, or LHI. The other 2 measures I will cover track non-fatal physical assault injuries and bullying of sexual minority high school students. I will provide more detailed definitions for each of the objectives as we proceed through each section. Next slide, please. I'll begin by discussing homicide deaths, objective IVP 9. Next slide, please. Homicide deaths are tracked annually with death certificate data from the National Vital Statistics System. The age-adjusted baseline for this objective is 5.9 homicides per 100,000 in 2018, and the target is 5.5. Note that except for data by age group, which are crude rates, the homicide rates I will share today are age-adjusted to the 2000 standard population of the United States. This objective has a progress status of getting worse. Next slide, please. This slide shows homicide death rates by race and ethnicity for 2018 and 2021. Throughout this presentation, when discussing race and ethnicity, we'll look at Hispanic ethnicity along with race groups, which exclude persons of Hispanic origin. The age-adjusted homicide death rate increased by 38% from 5.9 homicides per 100,000 in 2018 to 8.2 in 2021. From 2018 to 2021, age-adjusted homicide rates increased for the Black, Hispanic, 2 or more races, and white populations. Among racial ethnic groups, the highest percent increase between these years was for the Black population at around 49%. And between 2018 and 2021, the differences in age-adjusted homicide death rates for the American Indian, Native Hawaiian, and Asian populations were not statistically significant. Next slide, please. This slide shows trends in homicide death rates by age group for 2018 to 2021. Note that the target is derived from the total, which is age adjusted, and the target does not apply to data by age group, which are accrued rates. Therefore, the target line is not shown on this slide. Throughout this period, homicide death rates were highest among people ages 18 to 44 years. Between 2018 and 2021, homicide death rates increased for people less than 18 years, those ages 18 to 44 years, and those ages 45 to 64 years, but were not statistically different, rather, for people aged 65 years and over. Next slide, please. This slide shows age-adjusted homicide death rates by sex and geographic location in 2021. Compared to their counterparts, age-adjusted homicide death rates were higher among males and among those living in metropolitan areas. The rate for males, 13.2, was more than 4 times that for females at 3.1. Next slide, please. Next, I'll discuss non-fatal physical assault injuries, IVP-10. Next slide, please. This objective tracks emergency department visits due to confirmed and suspected injuries from an act of non-fatal violence where physical force is used with the intent of causing harm, injury, or death to another person, or an intentional poisoning by another person. The age-adjusted 2017 baseline objective is 496.7 non-fatal physical assault injuries per 100,000, with a target of 277.9. Next slide, please. This slide shows non-fatal physical assault injuries by sex between 2017 and 2020. The age-adjusted rate of non-fatal physical assault injuries decreased from 496.7 per 100,000 in 2017 to 402.5 in 2020. However, this change was not statistically significant. Similarly, rates for males and females decreased from 2017 to 2020, but the change was not statistically significant for either group. Next slide, please. This slide shows non-fatal physical assault injuries by age between 2017 and 2020. Like the objective tracking homicide deaths, the target for this objective is derived from the total population, which is age adjusted, and the target does not apply to data by age group, which are accrued rates. Therefore, the target, again, is not shown on this slide. Non-fatal physical assault injuries were highest among adults ages 18 to 44 years throughout this period. Between 2017 and 2020, while rates decreased for people aged less than 18 years, there was no statistically significant difference in the rates of non-fatal physical assault injuries among people ages 18 to 44 years, ages 45 to 64 years, and those aged 65 years and over. Next slide, please. I will now discuss bullying of sexual minority high school students, objective LGBT-5. Next slide, please. This objective uses data from the Youth Risk Behavior Surveillance System, or YRBSS, to track sexual minority students in grades 9 through 12 who reported being bullied on school property in the past 12 months. The 2021 baseline for this objective is 24.9%, and the target is 20.7%. Collected in fall of 2021, these data also represent the first Youth Risk Behavior Survey data collected since the start of the COVID-19 pandemic. Although most schools had returned to in-person instruction by that time, the time spent out of school for many students may have impacted the school-related variables. Throughout the remainder of this presentation, when I use the term sexual minority, I'm referring to high school students who reported being gay or lesbian or bisexual. Next slide, please. This slide shows data for sexual minority high school students who were bullied on school property in the past 12 months by race and ethnicity in 2021. Among racial and ethnic groups, compared to Black students, the rate of being bullied on school property was twice as high for white students and 57.4% higher for Hispanic students. There were no statistical differences when comparing the rates for Black students with Asian students and students of 2 or more races. Next slide, please. This slide shows data for sexual minority high school students who were bullied on school property in the past 12 months by grade level in 2021. Rates of being bullied were highest for sexual minority students who were in the 9th grade, 31.7%. It's important to note that with the shift to virtual and hybrid school instruction due to the COVID-19 pandemic, the survey, which is typically conducted biennially in the spring, was postponed to the fall in 2021. As a result, the survey population is slightly younger than the usual cohort for the WIRE BSS. Next slide, please. This final data slide for this objective shows data for sexual minority high school students who were bullied on school property in the past 12 months by sex and obesity status in 2021. There were no statistically significant differences in the rates between males and females, or in the rates between sexual minority students with and without obesity. Next slide. I will end by sharing some key takeaways. Next slide, please. Overall, between 2018 and 2021, homicide death rates, one of the leading health indicators for the decade, have increased. When compared to their counterparts, the Black population, adults ages 18 to 44 years, males, and those living in metropolitan areas had higher homicide rates in 2021. Between 2017 and 2020, there is no detectable change in the rate of non-fatal physical assault injuries for the total population. In 2021, bullying of sexual minority high school students differed by race and ethnicity and grade level, but did not differ by sex or obesity status. Next slide, please. Finally, I would like to thank and acknowledge the 2 work groups whose objectives were highlighted today, as well as the NCHS, ODPHP, and NCHH STP staff listed here for their contribution. I'll now turn it over to our next speaker, Robin. Thank you.
Hi, hello, everyone. My name is Robin Gao. I use it, they, and he, him pronouns, and I'm the director of the Education Institute at Bradbury-Sullivan LGBT Community Center. And today we're going to be talking about fostering communities of care for our LGBTQ+ youth. Next slide, please. So I want to give a little bit of an overview. I think sometimes it's helpful to have shared language to enter these conversations with. So I was just going to quickly define the LGBTQ+ community to help us enter with a shared understanding and talk a little bit about Bradbury-Sullivan LGBTQ Community Center. So the LGBTQ+ community encompasses lesbian, gay, bisexual, transgender, queer, and questioning folks. You'll see the plus to indicate the expansiveness of the community and that there are many identities that fall underneath our community that won't necessarily be reflected in the acronym. You may also see variations of the acronym that include the term intersex, and also the terms asexual, aromantic, or 2 or 2S, and that stands for Two-Spirit. Bradbury-Sullivan LGBT Community Center offers health, community, youth, and education programs, and we were founded in 2017. We are located in Allentown, but we have reach across the state of Pennsylvania doing LGBTQ+ work. Next slide, please. We're going to learn how to recognize current research on LGBTQ+ experiences with bullying and violence and the health outcomes caused by those experiences. We're going to evaluate 2 approaches that seek to reduce violence and discrimination and foster resilience in LGBTQ+ youth. And these are approaches that the center itself employs. We're going to summarize proven strategies for mitigating bullying and violence against LGBTQ+ people. Next slide, please. And throughout this presentation, we're going to touch on 3 different key connections to Healthy People 2030 objectives. We're going to talk about reducing bullying for lesbian, gay, or bisexual high school students, and then also connect some of those statistics to reducing homicides and reducing non-fatal physical assault injuries. Next slide, please. So I think that it's helpful when we're approaching these conversations to talk a little bit about history. Oftentimes we're looking in a very recent history when we're talking about statistics and data, but it's important to recognize how queer people, LGBTQ+ people have faced discrimination throughout history. I try to look at the most recent history, kind of taking us from the 1800s into the early 1900s. Through the 1800s, we see a criminalization of LGBTQ+ identities through laws like anti-sodomy laws and anti-cross-dressing laws. We see a shift in the early 1900s, which was viewed as progressive at the time, but today we can understand its negative impacts towards medicalization, viewing LGBTQ plus identities as some form of physical or psychiatric illness. And we could still see a lot of the effects of that process today. The impacts persist in the ways in which we police LGBTQ plus bodies, and oftentimes still conceptualize of them as like something that is wrong or an aberration. We face continued threats of violence, discrimination, and abuse that take their roots in this history. And that's important to acknowledge because it helps us also look towards what possible solutions there are out there. Next slide, please. So first, now we're going to talk about current research areas in bullying and victimization at school for LGBTQ plus youth. Throughout this presentation, you'll see me primarily reference two different surveys. The first is by the Trevor Project that was completed in 2023. The Trevor Project survey is one of the largest surveys of LGBTQ plus youth, so it tends to be the biggest source of information that we have for understanding the current state of LGBTQ plus youth safety, health, and especially links to suicide rates. So from that national survey, we can see about 53% reported being verbally harassed at schools. About 20% experienced unwanted sexual contact due to being LGBTQ plus. About 12% left school because of that treatment. And in that 12%, I also think about all the other kinds of different negative outcomes that LGBTQ plus youth experience that likely weren't totally captured by the survey. I can imagine impacts on grades, and there is other research that suggests impacts on grades, school participation, and other things that would help youth feel a sense of belonging in a school. Then 9% reported being physically attacked. And we'll see these statistics, if you look at the breakdowns, vary depending on school area, depending on people's specific identities. Sometimes specific identities face more forms of discrimination. I'm specifically thinking about trans and non-binary youth. And all of these statistics paint a picture of a space where youth often don't feel supported and don't feel a sense of belonging and connection to the community. Next slide, please. So looking at some more current research on violence, this is also still from the Trevor Project's National Survey of LGBTQ plus youth. About 24% of LGBTQ plus young people and 27% for trans and non-binary youth reported that they had been physically threatened or harmed in the past year due to their sexual orientation or gender identity. And this isn't specifically in a school space, but this can be out in the community, in a different kind of community space. And that is about 1 in 5 people reporting that. It's a really high percentage of youth who are basically experiencing something that's making them feel unsafe in areas that are out of their home or their own communities and towns. And the impact that we see on this is really wide ranging. And that kind of experience also impacts youth who might not have even directly experienced that violence. There's a lot of vicarious trauma that's experienced by LGBTQ plus youth, even just reading about these kinds of instances in the news or hearing about it from peers. It's the kind of thing that increases those feelings of not feeling like they belong in a space. Next slide, please. So continuing with more research on violence, this research comes from Bradbury-Sullivan Center's LGBTQ plus health needs assessment, which is a statewide health needs assessment. We do take youth data. The bulk of the data comes from LGBTQ plus adults in the state of Pennsylvania, but this is Pennsylvania specific data for youth. About 30.9% of youth listed violence as a health priority. So our youth are seeing violence as something that is rising to the surface when they think about what should the priorities of the LGBTQ plus community be. About 4 out of 10 respondents experienced violence from a partner or family member. And I'm going to talk a little bit about the connection to this and some of the work that Bradbury-Sullivan LGBT Community Center does, because oftentimes we think about violence as a stranger, but so often for our youth and for LGBTQ plus people in general, violence is coming from an intimate partner or even a family member. About 24% reported experiencing violence based on their LGBTQ plus status, which is similar to the data that the Trevor Project's nationwide survey did. I think it seems like it's a little bit slightly lower for Pennsylvania. But this is, again, Pennsylvania-specific data illustrating that current experiences of violence. And these are things that I see directly in my work at the center. A lot of people have different forms of trauma that they've experienced just from not feeling safe in spaces. I know that some people even feel not safe just walking from the parking garage to the center because of harassment that they face in other different kinds of spaces. So that's an example of how these statistics play out in real people's lives. Next slide, please. So I also think it's important to talk about some contributing and compounding factors that contribute to violence that are also linked to being LGBTQ+. One of the key health priorities that rises to the surface every time we do the LGBTQ+ health needs assessment, at least for LGBTQ+ people in the state of Pennsylvania, is feelings of social isolation and lack of support systems. And when we experience this kind of social isolation, whether we're in school or whether we're out in our community, it makes us vulnerable. And that also often makes us a target of violence and harassment. We also see that a lot of LGBTQ+ people live paycheck to paycheck and are struggling to have basic needs such as housing and food. These are also factors that make us more prone to encountering violence because we, again, become an easier target for either someone who is looking to act maliciously or maybe might be motivated by bigotry. But I think that a key factor really does come down to the combinations of these things. So if someone's socially isolated and then also lacks resources, that just increases their vulnerabilities. I also cite that the political climate has continued to be something that has increased violence against LGBTQ+ people. And this is something that I've seen from working directly with our community members. People report an increased amount of people shouting at them from cars, feeling unsafe just walking through the neighborhood where they might have actually felt safer a few years ago or even decades ago. I also say a general system of white supremacy as contributing to these factors of violence. White supremacy is a system that devalues bodies and specifically, centered around racism, but also devalues LGBTQ+ bodies, disabled bodies. That whole system works together to devalue the lives of LGBTQ+ people, and I can see how that results in different kinds of violence and at a younger level at bullying experiences. Next slide, please. So here I wanted to look at some of the impacts of violence. We're going to look at, on the left side, Pennsylvania data and then some national data. Overall, the biggest impacts I see are increased risk of suicide, all different kinds of mental health risks and disparities. We see an impact in folks not seeking help. And this help can be defined in a lot of different ways. It could be help as in reaching out to a doctor, mental health support, or even social services organizations designed to combat and support specific issues. And then we also see a decreased access to basic needs. So looking at the Pennsylvania data from the LGBTQ+ health needs assessment, we see about 41% of LGBTQ+ people have considered suicide. About 54% just experienced depression, which is about half. And 45.9% fear seeking help. And that fear seeking help statistic, I think, is important because the question is specifically worded in referencing that they might have experienced a form of discrimination in the past. So we can see a direct link to a form of violence or discrimination resulting in a behavior of not seeking help. And that question is specifically linked to seeking healthcare, but we can extrapolate and also look at other research that suggests that LGBTQ+ people also don't seek other forms of help. Then looking at the national data, about 14% of LGBTQ+ youth have attempted suicide. About 67% have anxiety, and about 21% have experienced homelessness. And that connects back to that compounding factors, the ways not having basic needs make us vulnerable to all different other kinds of discrimination and violence, and having probably multiple things happen, both bullying, physical violence, and all the ways that those result in impact in all these different ways. Next slide, please. So talking about intersectionality, I think, is really important when looking at this data and considering these issues. There's increased violence towards Black, Indigenous, and people of color who are LGBTQ+. And this violence is also experienced by folks of color who within the LGBTQ+ community. Oftentimes, white LGBTQ+ people will perpetuate racism and violence towards LGBTQ plus folks of color, making sometimes LGBTQ plus community spaces not always safe for LGBTQ plus folks of color. Respondents listed additionally, and this is research listed from the health needs assessment, so Pennsylvania specific data. Respondents also listed that ableism, sexism, fat phobia, living in a rural community, and age contributed to their experiences with violence and discrimination. So we can see respondents directly naming out the ways different identities intersect and combine to increase their risks, to increase their experiences with violence and discrimination. And I think that looking at all of this, we can see that connection again to that overall culture of white supremacy and the devaluing of certain people's bodies and experiences leading to direct forms of violence. Next slide, please. So now I'm going to move to talking about Bradbury-Sullivan LGBT Community Center's approaches to mitigating violence and bullying. I'm going to talk about two different approaches. I'm going to first focus on our youth program side, and then move to talking about the LGBTQ plus Education Institute. So the first program I want to talk about is called CAST. So it's Coping and Support Training. It's a coping skills training program for youth grades 6 to 8. The center provides guidance counselor education as well, along with this program on LGBTQ plus topics. And this group basically runs weekly each semester in 3 different middle schools. And students are identified based on risk factors, such as like low attendance, low grades, expressing depression, all those kinds of things, and also being LGBTQ plus. And this CAST training specifically, we see as a way of helping equip LGBTQ plus youth with emotional skills to possibly be able to develop resiliencies and mitigate some of those impacts of bullying. We also offer a parents group, which offers parent-specific information on LGBTQ plus topics, and it's moderated through a peer support model. And I think we can see how this could address some of those factors of oftentimes violence being perpetuated by family members. We believe a way of addressing that can be to equip family members with the knowledge and skills to be supportive and caring of their youth and see the different health risks that can result in not being supportive and caring. We also do youth-specific events and education materials such as mental health resources with handouts on resources like QChat and the county warm line so that youth also have additional resources that might be outside of our specific programming. Next slide, please. The Education Institute also offers school district specific training plans to train on LGBTQ plus equity and inclusion and specific barriers to success for LGBTQ plus youth. This year specifically, we have done a citywide education plan for Bethlehem and Allentown, and then also in their school districts, both at the city hall and then also in school districts to educate leadership on important LGBTQ plus health issues. These training plans really help to inform people from a higher position of the ways we should be thinking about LGBTQ plus health. Also, exposing people to LGBTQ plus topics helps normalize our experiences and kind of mitigate some of that othering that happens and that social isolation that results from being othered from basically most spaces. Next slide, please. So some of the programming's impact, CAST shows a decline in 2 specific suicide risk factors, which are suicidal ideation and suicide threats. We also see CAST resulting in an increase in mood management skills and other protective factors for suicide. We also see a decrease in drug use of participants. Now, this doesn't specifically combat bullying, but our hope is to equip LGBTQ plus youth, both with resiliencies, not that we expect them to just like endure bullying, but that they can have some different competencies to process the world and process the ways in which oftentimes LGBTQ plus youth are experiencing violence and bullying. We also see having a program in a school as a way of, again, normalizing the experiences of LGBTQ plus people, and working with guidance counselors and teachers helps create that buy-in from adults in those situations to help them learn how to intervene. For the Education Institute, we see 80% of workshop attendees displaying knowledge of terms and concepts and commitment to adopting practices from the training. And this is really significant because this is the kind of training, this is the kind of resources that people can take into their day-to-day lives and continue to make that impact on either youth they serve, if they're a school administrator, or in public policies, just to make people feel more comfortable at any kind of public organization, the city hall, all the different kinds of resources and services that community members access there. Next slide, please. So I'm going to talk a little bit now about current research on strategies for mitigating violence towards LGBTQ plus people and bullying. I think that these two things are deeply interconnected because I see bullying as a term that really describes the roots of violence that emerges as adults. And sometimes bullying can manifest in forms of physical harm towards youth's peers. So national research, and this is national research coming from the Office of Justice Programs in 2020, identified these recommendations as ways of mitigating violence. The first is to show support publicly. The second is to support and link parents to resources. The third recommendation is to advocate for inclusive faith communities. The fourth is to advocate for positive policy changes. And the fifth is to encourage LGBTQ plus youth groups to invite parents to kind of bridge those connections. Next slide, please. Some of the surveys addressing questions of bullying in schools are the Trevor Project's national survey that I've been talking about, and also the school climate surveys that the Trevor Project performs as well. Next slide, please. So looking at some other national research, this specific graph shows the proportion of LGBTQ plus youth who were bullied that were in LGBT affirming schools compared to those who are not in LGBTQ plus affirming schools. And we can see the affirming schools all report a lesser rate of bullying. And we're going to continue to talk about those factors that create an affirming school because we can see how that decreases bullying. And I think if we look at it over time, we'll continue to see that decrease as school officials and administrators become more informed on those practices. Next slide, please. So what are affirming spaces? The Trevor Project's national survey identifies GSAs, supportive classes and groups, and supportive teachers or school officials as markers of affirming spaces. I think that idea of having a specific group, like a gender and sexuality alliance, is really key to that creating an affirming space because that illustrates that a school is really specifically valuing the experiences of LGBTQ plus youth. And I think that a lot of these tendencies or these things that mark an affirming space can be applied to adult spaces as well. Are there specific LGBTQ plus affinity groups? Are there areas and places for LGBTQ plus people to feel supported? And is there support from officials or leaders in an organization? Next slide, please. So the impact of these affirming communities illustrates a reduced suicide risks, improved grades, positive impact on mental health, and positive culture in general, which we've seen to impact not just LGBTQ plus youth, but their non-LGBTQ plus peers as well. And this is coming from research, again, by the Trevor Project, and then also through the LGBTQ plus health needs assessment. So there is a lot of hope in that the impact of these affirming spaces can really radically reduce the impact of violence and bullying on the LGBTQ plus community. Next slide, please. So some key practices accumulated from a different school climate survey say to enforce non-discrimination policies, have community or school LGBTQ plus organization, and supportive and vocal leadership. So we can see how that mirrors some of the recommendations of the other studies as well. Next slide, please. So looking at other ways to support youth, we recommend getting in touch with our youth programs, looking at GLSEN for further resources. Again, the Trevor Project, resources through their Human Rights Campaign, and Q Chat Space, which is a specific social worker moderated chat space that helps LGBTQ plus youth work through questions and problems. Next slide, please. And that's my bibliography. Thank you so much for hearing us and excited to answer some questions in the Q&A.
Thank you, Robin, and thank you to all our speakers for the wonderful presentation. So I'd like to invite all of our presenters and the Healthy People Topic Area Work Group representative to join our moderated question and answer section. So if you're participating in that, please turn on your camera. We had a number of questions come in, and it will be exciting to make our way through these. The first question is going to go to all of our panelists, and I'll ask Robin to start out with an answer, and then she can Robin can pass it over to Christina. So what guidance or information can you provide to communities seeking to identify public health challenges such as violence in their communities, and what are some initial steps that communities can take to address these challenges? So Robin, if you could please start out with that one.
I think the key is to really ensure that there are LGBTQ plus people in positions of leadership, and maybe in working groups or focus groups. I think oftentimes if we're not leading voices, we aren't going to see the full picture of how that violence is impacting LGBTQ plus people. I think a key example is oftentimes homicide statistics don't take into account if someone is trans or LGBTQ plus. So oftentimes there's a lot of really significant knowledge that is held by community members that we don't have an accurate way of like capturing always at every moment. So I think like a biggest key is having all different kinds of community input and ensuring that that group is diverse too, because the experiences of LGBTQ plus people with violence really varies based on, like I said, those other forms of discrimination and marginalization. So that's what I would say.
That's great. Thank you. Thank you for that response. And Christina, could you take a turn answering that, please?
Yeah, absolutely. I 100% agree with Robin. I couldn't have put it better myself. I think it's really critical to have both folks who are experienced in working in the systems that they're working in, whether it's the community, state, federal level. It's really important to have folks who identify with the populations that they're working with, and also developing that subject matter expertise for working with those communities. Community-based participatory research is really important for informing how we can best help and support those communities.
That's great. David and then Carter, would you like to respond to that as well?
Sure, I'm happy to. Thanks for the question. And from a federal kind of data perspective, I would point folks to the Healthy People 2030 objectives related to violence. And a lot of these are found or housed in the injury and violence prevention topic area. Users can find that topic area by going to the About section on the Healthy People website. And then there's a work groups selection that users will want to go to, and then go to the injury and violence prevention hyperlink there. And there are a variety of violence-related objectives there. They range from homicide deaths and physical assaults, which I covered today, to some topics that I didn't cover, such as firearm-related deaths, sexual and intimate partner violence, violence against children and adolescents. And these can be found not only in the IVP topic area, but also a couple of others as well. There's one in the adolescent health topic area, AH10, that addresses violent offenses committed by minors and young adults. There's also one in occupation and occupational safety and health, or OSH, objective 5, which is looking at work-related assaults. And the majority of these objectives do have national level data for the total population as well as for subpopulations. And furthermore, these objectives also have evidence-based resources that focus on violence prevention that users can find on the Healthy People website. Thank you.
And then I'll just add on to what Robin, Christina, and David have said, to say once you have identified the challenges and you have the data, you can look at the national data to help guide you, or whatever local data you might have. Work with those subject matter experts and community leaders that you've identified and actually develop a plan for moving forward. And if you're modeling after Healthy People efforts, you would establish what would be your objectives and set a target of where you want to go. The way to measure progress is, you know where you're starting, and you want to know where you're going, and you can gauge your success. Doing that can help you marshal forces in different ways, whether it's just community support, funding support, etc.
That's great. Thank you all for your responses. Robin, we have a question related to some of the survey aspects of the presentation. The first one is, did your survey ask about suicide ideation attempts and or access to lethal means?
Our specific survey did not look at the access to lethal means, but I believe it did look at suicide attempts. It didn't ask for like frequency, but it did ask for specifically like if you had attempted within like the last year or within your lifetime. And we saw similar numbers for both the last year and lifetime for like overall LGBTQ plus folks.
And then, Robin, another question related to the survey and data presented. Are there individual statistics based on not seeking help for discrimination versus experiencing violence?
I don't have a statistic that specifically differentiates the two, but I would encourage people to think about how like deeply those things are interlinked, and that not all violence, I mean, we're defining violence specifically in a very specific way based on the 2030, you know, guidelines. But I would encourage people to see the linkages there and to see discrimination as a form of violence towards people, especially when it's preventing people from getting the specific kinds of care that they need. But I don't have specific ones on, the differentiation. I would just imagine that if people experience like a direct form of physical violence, that number of not seeking care would probably go up.
Thank you. Christina, a question related to an LGBT objective and healthy people that's managed under the LGBT health work group is why is LGBT05 not inclusive of trans identities? Could you answer that for the audience, please?
Yeah, absolutely. So we actually have another objective that focuses specifically on gender minority youth and bullying, specifically getting at those trans and non-binary folks. And we don't have the data quite yet. I know that YRBS has added gender identity questions, so we hope that that will soon be a measurable objective. And then we will have sort of two complementary objectives to be able to address both sexual and gender minority youth.
Great. And I'll open this up to the entire panel for anyone that would like to answer. Wondering is one of the audience members is wondering if sport and play have been intentionally utilized to create supportive communities for LGBT youth, and if anyone is aware of any case studies for this as well.
So I can start with that. Within the Office of Disease Prevention Health Promotion, where the Healthy People Initiative is housed, we also house the President's Council on Sports, Fitness, and Nutrition. And under that council, a plan called the National Youth Sports Plan was released several years ago. And it does encourage youth sports across all youth populations, including LGBTQ youth. So we're trying to elevate the importance of sport across all youth populations. So that's you could go to health.gov and find that plan. So it's something that we're very excited about, and it has gotten a lot of traction.
Thank you. That's very helpful. Any other panelists would you like to add to that, or should we move to the next one?
I would just offer from an anecdotal point that the kinds of programming that we do for queer youth at the LGBT Center really illustrate ways in which those spaces of queer joy can really be impacting our youth in a really positive way. Everything from like a t-shirt making event to playing board games. Those are spaces that queer youth don't often have access to, especially if they're in a school district that doesn't specifically have a very active GSA. So I would just offer that from being able to work directly with youth and seeing the ways in which that really makes people, brighten up and come alive in ways that they might not in their day-to-day life.
That's great. Thank you for that addition. Robin, we'll pass this one to you as well. How do we make sure our data, or sorry, our work is data driven and relevant when LGBT data at the state or local level may not be available to really inform those choices?
I think sometimes I go back to talking to the community in whatever kinds of survey or like focus group ways that you can. I think oftentimes data can be violent in a lot of ways towards our community. I mean, even just looking at some data that we referenced today, we see referencing only male and female. We don't see ways in which that captures the experiences of intersex folks, and sometimes might misrepresent the experiences of transgender people. We try our best with what data can do, but I really believe in listening to people's direct experiences, because oftentimes we're missing a lot of pieces of the picture that as community members have pieced together that the data might not always represent. I think a really big example I think about this is trans folks and our accesses to healthcare or safer affirming spaces and what that means for us. Oftentimes our experiences have been deliberately excluded from medical research or medical spaces. And so we have to share resources within one another. So I think it's about really earning the trust of communities and taking those times to really deeply listen to people beyond just like a survey.
That actually leads really well into another question we have about creating affirming spaces. So any information that can be shared about how we can create affirming spaces in schools and communities or states where the discussions around LGBTQ plus may be discouraged.
Hey, Debbie, can I actually just chime in a little bit to what Robin
Please.
said on that last question? Because
Oh,
I think it's a
absolutely.
really important point, especially in the context of having representative, equitable data for all of the critical populations that we're trying to serve. In January, a group of federal working group published the Federal Evidence Agenda on LGBTQI plus equity under the charge from President Biden's Executive Order 14075, and it calls for increased and reliable data collection to serve LGBTQI plus populations. Now, we recognize there's a lot of challenges since there are some state-specific anti-LGBT stuff going on, and that can feel very vulnerable for many communities that this affects. But we also don't have any way to be able to track the communities that are being affected when we don't have nationally representative data collection. So I think it certainly is a double-edged sword, and I think it is certainly strengthened, as Robin was saying, by having community members doing that work. So I would just say that it's also really important to make sure that where there is data collection happening, that it needs to be community informed and evidence-based, and in all situations protecting the privacy of the folks who are willing to share their information.
That's great. Thank you for that addition, Christina. That was an excellent point. So thank you for that. So we'll go back to that, guidance or advice around creating affirming spaces, particularly in areas where, discussions around LGBTQ plus may be discouraged.
I think it usually comes down to two things. And the first is education and really educating people in roles of leadership around both like specific kinds of health inequities, and then also like a basic kind of cultural competency on understanding LGBTQ plus identities. I think if we don't understand the language that our community is using, we can't relate and we can't build those bridges and kind of earn back that trust that LGBTQ people have really overall often lost in systems that are meant to care for us. And then the other part is having those LGBTQ plus specific kinds of spaces, whether that's a GSA, whether that's a healthcare provider who knows and is really specifically educated on specific health concerns LGBTQ plus people might have. I think it's both that education and then also uplifting and centering LGBTQ plus people in roles of leadership.
Thank you. Thank you. David, this one's for you, and it's about the Healthy People data and asking if you have any data on overdose deaths or aware of any data on overdose deaths within Healthy People.
Sure. So I also did drop some of this information in the Q&A box But just to kind of reiterate that response, we have several objectives in Healthy People 2030 related to overdose deaths. There's an overall drug overdose deaths objective in the substance use topic area. It's SU objective 3. And then there are several in the IVP topic area that specifically track overdose deaths due to opioids, either generally or specific opioids. And those objectives are numbered IVP 20, 21, 22, and 24. And again, we have data for the total population as well as for demographic groups, which you can find on each of those objective pages in the data tab. There's also more detailed information about how each objective is measured in the data methodology and measurement tab. Thank you.
That's great. And that's all the time that we have for questions today. I want to thank everyone for joining. If you follow the health.gov page, the recording for this webinar will be available, and you can keep an eye on that. The continuing education information was also available in the slide deck. So thank you again for all the time and effort that went into this webinar, and we will see you at the next quarterly webinar. Thank you.